Good afternoon, everyone, and thank you for joining us today at the Women's Health Summit. I'm Dr. Jeannine Villella, Vice Chair of Gynecology and Chief of Gynecologic Oncology at Lenox Hill Hospital, an Associate Professor at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell Health. I'd like to thank the 92nd Street Y for organizing this Women's Health Summit and the Katz Institute for Women's Health and Nancy and Larry Roth for helping this event become possible. Today's topic is going to be on cancer, with a focus on prevention. This important conversation is especially relevant in today's world. We know that many have been delaying screenings due to the COVID-19 pandemic. We cannot let the COVID-19 pandemic create a second group of victims, those who need cancer care. It is safe to resume mammograms, colonoscopies, pap smears, and other screening tests. And the best outcome for cancer is early detection. We know the earlier that cancer is diagnosed, the quicker you can be treated and the more likely you are to be cured. More than 1 in 3 women will be diagnosed with cancer in their lifetime, so this is truly important. Our day will open with Fran Drescher, a 20-year cancer survivor, founder and visionary of the Cancer Schmancer movement, dedicated to educating, motivating, and activating patients into medical consumers by connecting lifestyle to disease. We will be addressing cancer prevention and innovations in diagnosis and treatment. Dr. Richard Barakat, Senior Vice President for Cancer Services and Physician-in-Chief and Director of the Northwell Health Cancer Institute, will be moderating a panel of experts. And we will spend some time today addressing controversies related to cancer screenings, so you'll be armed for the information you need. And cancer survivorship will be the focus this afternoon, since cancer care is not just about eliminating the disease, but it is about keeping people healthy, active, and feeling good as possible for the rest of their lives. Thank you for joining us.
Hi, I'm April Long, the Beauty Director at Town & Country. I want to start by thanking the 92nd Street Y for producing such an important event to spotlight crucial topics related to women's health. Town & Country is so proud to participate as the national media sponsor. Town & Country has covered beauty, wellness, and mental health for decades. In fact, it is our 175th anniversary this year, and this event aligns perfectly with our May Beauty and Wellness issue and our June Philanthropy issue, which you will hopefully be seeing very soon. Now for the truly exciting part. I am so happy to be here today with Emmy-nominated actress, activist, and philanthropist, Fran Drescher, to talk about her personal experiences with fame, cancer, and philanthropy with her nonprofit, Cancer Schmancer. Welcome, Fran.
Thank you. Thank you so much. I'm delighted to be here.
Thank you. Well, so Cancer Schmancer began as a book and became a movement. What was it about your experience with your diagnosis and treatment that sort of made you see the need for such a platform?
Well, it took me 2 years and 8 doctors to get a proper diagnosis with uterine cancer. Honestly, I got in the stirrups more times than Django. So I thought when I finally got diagnosed and I was recovering from a radical hysterectomy, that I didn't want what happened to me to happen to other women. And it wasn't until I decided to write the book and then ultimately go on my book tour that I actually started speaking to people all across America. And I realized that what happened to me was not uncommon, but extremely common by means of misdiagnosis, mistreatment, and for many, the unfortunate consequence of late stage cancer diagnosis. I was very lucky because even after 2 years and 8 doctors of misdiagnosis, I was still in stage 1 when I was ultimately diagnosed because I had a slow growing cancer. But had I had, ovarian cancer instead of uterine cancer, I surely would not be here today. And most women with ovarian cancer are usually diagnosed in the late stages. And 70% of them will die. So it really motivated me to start to think, we have to transform from patient into medical consumer. We have to start challenging our physicians more, becoming more partners with them, and knowing what tests are available for the cancers or any kind of disease that you may have, because very often it's not even on the menu at the doctor's office if it doesn't happen to be a test that your insurance company covers. So, there was a lot of things that I learned the hard way that I wanted to share with people. And that was the impetus for the book. And then the book became a New York Times bestseller. And I realized that it wasn't the end, but just the beginning of what's now become a life mission.
It's amazing. What are the key things that you want women to understand about navigating the health system and being active participants in their treatment?
Well, I think that particularly with women who tend to be the caregiver to the husband, the spouse, the children, and the elders in almost every home nationwide, they historically put their own needs last. And that's not good, because you're useless to your family if you're 6 feet under. So you have to reprogram yourself and start to pivot your thinking to, you feel something, it's in the whisper stage, so it's totally tolerable and easy to ignore, but that's exactly when it's the most curable. And so that's when you have to say, well, this could be nothing, but God forbid it's something. I want to catch it while it's still in the whisper stage, because I want to be alive and well for my family. So that's the cornerstone for everybody changing the way they think and about their own health, particularly women. Pick up that phone, make that appointment. And if you're with a doctor that's not really listening to you, not really paying attention to you, making you feel rushed through the appointment, then you have to find another doctor. Do not stay with that doctor that's not the right doctor for you. And if I didn't go to doctors 2 through 8, I wouldn't be here today. But I happen to be the type of personality. I'm a producer. I'm in a position of, power in my career where I'm, I easily will say, I don't think you know what you're talking about. I may not say it to their face, but I would think it. And I say, I have to find somebody else. I'm not satisfied with this, performance. I'm not satisfied with the way they're treating me. So, I really feel very strongly in my conviction that every woman has to have that kind of tenacious attitude about their own health and well-being. You are important, very important. And when a woman is lifted out of the equation of the family, it is devastating and very difficult to recover from for many decades. It not only affects everybody in that household and the community in which she lives and her extended family, but those children grow up differently and with a lot of pain. And so they carry that on with the rest of their life. And that impacts their relationships and how they deal with their own children down the road. So it's the tentacles of this, situation of having a sick mom in the home is really far reaching and can span generations, as well as outward, has a ripple effect throughout the family and the community. So you have to think about that. You are important. And you're not just there to put food on the table and get the kids dressed and get the husband off to work. You don't realize that you're systematically compromising your immune system. And if your immune system is compromised, you don't have a fighting chance. You really have to honor your body, bolster your immune system. And in supporting those two efforts, you have to clean up your act. You have to think about what you're eating. And if you're not eating organic and you're not eating foods that are not industrial farmed foods, usually laden with toxic chemicals, pesticides, herbicides, hormones, antibiotics, you name it. That's what's in industrial farm foods. We're getting very used to being surrounded by people getting all kinds of sicknesses. And really, what we get sick with is not as relevant as the causation, because it could manifest differently in different people. And that has to do a lot with, who you are, what your genes are, where do you live, how stressful is your life. All of these things will impact each person differently. But if we're all doing the same unhealthy things that not only hurt ourselves and our families, but also the planet, the water, the air, it's just, I'm surprised that I have to pontificate on this and educate people this way. It seems like a no-brainer to me, but I think that most people are very easily seduced into believing what advertising and manufacturers tell us. And we've been brainwashed into thinking that, having fast food is modern and convenient, when actually it compromises our nutrition and the quality of our food. And, that's just the tip of the iceberg.
Yeah.
If you're eating a strawberry that's not organic, you might as well be eating a sponge soaked in pesticides. If you're using toothpaste that says, do not swallow, well, that's counterintuitive for something that I'm constantly putting in my mouth and in my gums, which is the gateway to the rest of the body. You cannot be using that. And so, it's time for us to think about all these things. Get down on your knees and pull out the weeds on your lawn and in your gardens. Don't put pesticides and herbicides down there, because you're killing all of the microorganisms in the earth. And that's what makes the plant strong. It's what makes your food nutritious. It's like, we've been sold this bill of goods that we have to kill the weeds, kill the bugs, and ultimately what we're really doing is killing ourselves. There's always going to be bugs and there's always going to be weeds, and we can't keep up with that. Yeah. But, these are chemicals that were designed for war, which in itself is so repugnant to think about. But then when the war was over, they decided to repurpose it on civilian life. And so we got brainwashed into thinking that we need all these toxic chemicals in our everyday life. And you know what? We don't. And stop using it. That'll be the most powerful thing you can do to influence the world and the planet.
Yeah, connecting these dots is so important, and you've done such an amazing job at it. What achievements are you proudest of that Cancer Schmancer has achieved over the years?
Well, I did a lot of lobbying in Washington, and we were very successful in getting a bill passed by unanimous consent, which means all 100 senators said yes. So we passed the Women's Gynecologic Cancer Education and Awareness Act, the first of its kind in US history. And that's important because I felt like women don't really know enough about recognizing the early warning whispers or knowing the tests that are available. Or for that matter, being offered as basic gynecologic care, a transvaginal ultrasound does not exist. You're really only offered a bimanual pelvic exam. And in these days with so much obesity, that's not really sufficient. But they only offer the transvaginal ultrasound if there's a belief that there's a problem or if you're pregnant. But I feel like it should be standard part of a woman's annual gynecologic exam. That's one thing. And then the other thing is, you know, they always say that ovarian cancer is a silent killer, and that's not true. There are whispers that come along with the early stages of ovarian cancer that most women are not educated about. If you are gaining weight and there's really no reason for it, if you have intestinal problems, if you've been diagnosed with irritable bowel syndrome, that's often a misdiagnosis for ovarian cancer. And I always tell women to take a CA 125 blood test. It's a very simple blood test that's taken in the office. It is not paid for by health insurance, but I always tell women, you know, save your Christmas Club account for tests that your insurance won't pay for, because the best gift you can give your family is a long and healthy life. So the CA 125 blood test, they don't want to pay for because they say that it has a high false positive. But if you're negative, then you know at least it's not ovarian cancer. And if it's positive, then I would, you know, practice, you know, good medical practices, which would include going for a second test a few months later and seeing the accuracy of that prior to rushing into some exploratory surgery, or taking the next step and doing a transvaginal ultrasound. You know, I mean, there are things you can do, but for whatever reason, they think that women are incapable of, you know, getting information and making a grounded decision. And so we're really left in the dark until it's too late. And we're told that, you know, it's just a silent killer. And the only thing that's the killer is big business health insurance that doesn't really want to cover certain tests, and doctors that refuse to give women the option to pay for it themselves.
And so what's your advice for women who have been newly diagnosed, or for those who are, you know, have loved ones who are battling cancer?
Well, I think that get yourself a posse of really strong, supportive, intelligent people that are not going to make them about them, where you feel like you have to calm them down. No, this has got to be entirely about you. You get yourself a little group. Someone always has to go with you to these appointments. Have the pen and paper handy. Write down questions way before you show up to the appointment. Run through those questions. Have this friend of yours or relative there writing down the answers. Ask the doctor how to spell something if you don't know how, because your head's going to be swirling in a million different directions. So that's one thing. Learn to make it about you, because it is about you, because it must be about you, because this is your new job, to fix this and stay alive. And you have to be very proactive, and you may not feel like it. You may feel like just getting into a fetal position and sucking your thumb, but you can't do that. You can't become infantile, and you can't put your life in the hands of somebody else. It doesn't matter if they're a doctor, you know, because when the doctor calls and tells you have cancer, at the end of the day, he goes home and eats dinner with his family. You go home and eat your heart out with yours. It's your life. So at Cancer Schmancer, we present with our annual health summit and other programs throughout the year. Very outside of the box thinking medical doctors who went to medical school, drank the Kool-Aid, started practicing, and suddenly got woke and thought there's got to be a better way. And so they started connecting all the systems in the body, not keeping every part of the body as its own entity, but actually understanding that there are key systems in the body that work with different organs all together. And unless you have an understanding of that, you know, I like to compare it to when you have an apple tree that's yielding sick looking apples. Are you going to try and fix each apple No, you're going to look at the trunk of the tree. You're going to look at the roots of the tree. You're going to try and find out why the apple is yielding sick-looking apples, why the tree is yielding sick-looking apples. You're not going to just fix the apple. You got to figure out systemically what is wrong with this tree. They don't do that in Western medicine these days for the most part. Most of what's wrong with us is because of the way we live.
Prevention is everything.
Exactly. Captured on arrival, 95% survival too.
Mhm.
So first you have to live a preventative lifestyle. You know, if you take care of your immune system will take care of you. And then if you feel something wrong, become very proactive, because early, you know, the earliest whispers is your absolute best opportunity for surviving.
Thank you. We are out of time, but thank you so much, Fran. For
Oh, I'm so grateful for you giving me this opportunity. And I hope that all of the listeners go to cancerschmancer.org, because we are there for you. Let me help you stay healthy and well for many decades to come. And we have so many free, beautifully produced educational programs that will really blow your mind. So I hope everybody goes and participates in the Cancer Schmancer organization.
Thank you.
You're welcome. Be well.
You too.
Good afternoon. I'm Dr. Richard Barakat. I'm the Director and Physician-in-Chief of the Northwell Health Cancer Institute. And I'm really pleased today to be moderating a panel discussion with experts in the field of breast, ovarian, cervical, and colorectal cancers, who will offer insights about what we need to know when it comes to cancer screenings, risk factors, and preventative measures to help lower the risk of getting cancer. Please welcome me in joining our panelists, Jocelyn Park. Jocelyn.
Hi, my name is Jocelyn Park. I'm the Associate Chief of the Division of Breast Imaging, Eastern Region of Northwell Health, and I'm happy to be here today.
Great. Benjamin Schwartz.
Hi, Dr. Barakat. Thanks for including me. I'm Ben Schwartz. I'm a gynecologic oncologist and the chair of the Department of Obstetrics and Gynecology at South Shore University Hospital.
So I'm Andrea Zimmern. I'm a colorectal surgeon at North Shore and LIJ.
Great. Thank you all for being here today. When it comes to cancer, clearly early detection is one of our best defenses. Screening is one of the most important preventative measures to catch cancers in early stages, especially when there are no obvious signs and symptoms. And statistics show that the earlier cancers are diagnosed, the better the chances are of a positive outcome. One of the difficulties that we've seen during the pandemic was studies by the National Cancer Institute's modeling branch, which showed that because of the reluctance to undergo cancer screening, they're predicting an additional 10,000 deaths from colon cancer and breast cancer over the next decade, which I think really highlights the importance of screening and why we can't let cancer become one of the second morbidities and mortalities related with COVID. So this issue of screening is real and very germane to what we're all going through now with the pandemic. The statistics are sobering. 1 in 8 women in the United States will develop breast cancer over their lifetime. And this is mostly in women. There are male breast cancers too, much more rare, of course. And Dr. Park, this is your field of expertise. Clearly, there's been a lot of controversy about when women should start getting their mammograms. It seems sometimes like a moving target. The dates have changed, and the frequency and the types of testing. So it would be great if you could just provide some clarification on this, because I think in the public, there's a little bit of confusion, perhaps even amongst doctors, about what we should be doing.
Sure. So yes, I can understand why this can be very confusing for women and physicians, but I'm here to hopefully simplify everything and clarify. So long-term studies show that annual screening mammography starting at age 40 results in the greatest reduction in mortality from breast cancer, up to 30%. So here at the Northwell Cancer Institute, we do recommend that average risk women start screening at age 40 annually, because this will save the most lives. In terms of the variances in when to start mammography or how frequently to do mammography, those are really discussions about weighing risks of mammography to the benefits. So that's what the controversy is about, when to start and how frequently. And I think women just need to be informed about the risks and benefits and have a shared decision-making with their physicians about their breast health. So what are some potential risks of screening mammography? We can discuss. So one thing is the idea of false positives. When you have a mammogram, you may be recalled by the radiologist to get a few more views to look at a potential abnormality. Or your images may show something that requires tissue sampling or a biopsy that eventually won't show cancer, but those are additional tests that could result from a mammogram. And those are considered false positives and can induce some anxiety. There's a small potential of overdiagnosis, is something that's been discussed, where a mammogram could find a cancer that's so slow growing that it would not have caused significant issues in a woman's health had it not been found. So those are some issues that are discussed that a woman can discuss with her physician. But then the benefits, as we stated, the risks in screening earlier and more frequently does decrease mortality the most. And finding a breast cancer early often results in less aggressive treatments and may obviate the need for other treatments such as chemotherapy or radiation.
Great, that's great. And just to touch on the one point that I brought up, patient hesitancy during COVID, are we seeing things back to normal? Are patients reassured that screening is safe and they should come in for their screening at this point?
Yes, definitely. We are just as busy as ever, and we're happy to be able to give this service to patients.
Great, that's really fantastic. And the guidelines for colorectal cancer screening have changed recently. I know it's something that we're trying to make sure everyone is aware of it. So when should women start to get screened, and what is the best screening test for colon cancer? We hear of tests like just imaging tests versus colonoscopy versus stool samples. So tell us a little bit about that, if you could expand on that, please.
So the American Cancer Society lowered the screening age about just over a year ago from 50. We used to screen everyone at 50 years old, your average risk, and they lowered it to 45. We're seeing a lot more young people with what we call young onset colorectal cancer. And it took a little time, but the US Prevention Task Force just recently this year also recommended lowering the screening age to 45. So if you're average risk, you have no risk factors, no family history, no genetic disorders, no inflammatory bowel disease, those are all reasons that you would get screened sooner, then you would go at 45. And like I said, if you have risk factors, so a first degree relative that had colorectal cancer, you need to get screened at 40. You may even need to get screened sooner depending on the age of your family member that had colorectal cancer. So that's something you should discuss with your doctor. As far as which tests are the best, there's no way around it. A colonoscopy is the best test. The reason that is because it's not only diagnostic, but it's also therapeutic, meaning while it can find something, you can also address it at the same time, or at least biopsy or do something about it. All the other tests, while they're good, and I'll talk a little bit about them, they are purely diagnostic, meaning they can only find things. So you may still need a colonoscopy. So you may go get this other test because you don't want a colonoscopy. And if you have something found on one of these tests, you would still need a colonoscopy to then further investigate. The other tests that are available, probably the more common ones I would say are a virtual colonoscopy, which is kind of like a CAT scan. And Cologuard, which is the brand name, but a stool test that tests for DNA of large polyps and cancers. They're both really good tests. Their sensitivity and specificity, meaning how good they are at picking up on things and how right they are when they do pick up on things, are very high, over 90%. But again, if something is found, you would then still need a colonoscopy. Those tests are good for people who really are afraid of getting colonoscopies, although that's something you can discuss with your doctor, what your fears are, and maybe they can kind of reassure you that colonoscopies are safe and not as bad as you might think. And also, some people have some medical conditions that would preclude them from getting a colonoscopy or having anesthesia. People on blood thinners might want to be more cautious about getting a colonoscopy. But again, something to talk about with your doctor. It doesn't mean you can't have a colonoscopy. We do them on all sorts of patients all the time. It's very safe and hopefully, something that wasn't as bad as you thought it was going to be.
That was great, Dr. Zimmern. Thank you for all of that information. And I'd like to follow up with another question similar to what I had asked Dr. Park. The concern is that patients weren't showing up for their screening tests, their colonoscopies, as they should be doing because of what was happening during the pandemic. Are we seeing patients now getting those tests done? Our fears, we don't want patients to present with more advanced disease should they happen to have colorectal cancer.
Sure. Yeah. I mean, of course, during the pandemic, when it was at its worst last year, we kind of had to shut certain things down. But now that things are back to normal, we are up and running. We are doing colonoscopies again in our offices. We are obviously taking the right precautions, but patients are coming back. It's safe, and we wouldn't do anything that wasn't safe. And we encourage people to come do all their screening tests, including their colonoscopy.
Yeah, no, that's great, Dr. Zimmern. I'm glad to hear that because it is so important for patients to undergo their screening when they do. So now I'm going to turn it over to Dr. Schwartz and a topic that I'm quite familiar with. I'm also a gynecologic oncologist like Dr. Schwartz. So when it comes to gynecologic cancers, specifically cervical and ovarian, what information do we need to know? I think one of the things that's really evolved over the years that I've been in gynecology is the current guidelines for screening for cervical cancer. Does it involve pap smear? Does it involve screening for HPV? And also, if you could touch a little bit upon the current recommendations for HPV vaccinations, which I think are a success story.
Sure, thank you, Dr. Barakat. So with regards to ovarian cancer, I know that later in the program, we'll talk a bit about the symptoms that can be related to gynecological cancers. But I think when we talk about pap smear for cervical cancer and symptom monitoring for ovarian cancer, the most important take-home message is to go to a qualified provider at least annually, and to be a bit of a self-advocate. Some people call ovarian cancer the disease that whispers because the symptoms can be quite subtle. And I think it's really important for patients to reach out to their providers if they have concerns. There's been a lot of changes over the course of our careers regarding how frequently women should have pap smears. I just want to, before I go through those, I just want to reiterate, even if you're not getting a pap smear at every visit, it's still important to be going every year to a qualified provider for a gynecological wellness exam. But with our understanding now of the human papillomavirus, we know now that there are certain high-risk strains of the human papillomavirus. That HPV is a family of viruses, some of which are much more dangerous than others. And the overwhelming majority of cervical cancers are caused by those high-risk HPV strains. Now, the challenge is that it's estimated that as many as 80% of women over the course of their life will have an HPV infection. And so not every HPV infection means that a woman's going to develop cancer. So generally speaking, the American College of OBGYN has in their most recent guidelines, which are from last year, that women should start having a pap smear at the age of 21. And it really should just be a pap smear every 3 years until they turn 29. Once they turn 29, then the guidelines leave open different options. The one that I like the most is to have a pap smear, which is looking for abnormal cells on the cervix, in combination with an HPV test at least every 5 years until you turn 65. At the age of 65, I think we assess whether or not you've ever had an abnormal pap smear. If you've had frequent normal pap smears in your past, you can really stop them because you're considered very low risk. But if you've had abnormal pap smears or if you have a high-risk HPV infection, the pap smears should continue. So there's been a lot in the news lately about vaccines and the safety of vaccines and concerns that young women in particular have regarding the risk of vaccines. I think a lot of the concern about COVID vaccines comes from the fact that they came out onto the market so quickly. But actually, the HPV vaccine has been around for quite some time. It's used internationally. not unlike most vaccines, it's best to get the vaccine before you're exposed to HPV. So it's approved for young girls starting at the age of 9, where the ideal age is probably around 11 or 12. And initially it was approved up to the age of 26. However, we're learning now that in women that have not previously been exposed to HPV that may be at risk of developing an HPV infection going forward, the vaccine can be used up to the age of 45. And Dr. Barakat, as you know, there are some countries in the world where they universally use the HPV vaccine, and they've nearly eliminated cervical cancer in their populations. So I think, this vaccine's been around for a long time. Its safety is well known, and there really is a role for universal use of this vaccine to eliminate this very dangerous disease.
Yeah, those are great points, Dr. Schwartz. And I think highlighting those countries like Australia, where the vaccination program is done through schools, they have literally eradicated, and it's not only cervical cancer. We as oncologists tend to focus on cancer, but there's so many other comorbid conditions that can be associated with human papillomavirus, including genital warts and other conditions which are quite disturbing to patients. So I think it's great, and hopefully the public will go ahead and get those vaccinations because they are so critical. So I want to pivot a little bit. We're talking about screening today in general, which is clearly important, but we tend to focus on the woman at average risk, but we all know that there are a subset of patients often associated with genetic syndromes that are at much higher risk of developing cancer. And do those same screening recommendations apply in these high-risk individuals? So Dr. Park, I'm going to go back to you. And if you could just tell us a little bit more about what the considerations are that would put a patient in a more high-risk category and how that would change their screening recommendations.
Sure. So there are multiple factors that can go into a woman's risk for breast cancer and elevate her above an average risk woman. But basically, the biggest risk factor is just being a woman. As we said, men can get breast cancer, but women are at much higher risk. And age, as you get older, most breast cancers occur in women who are 55 and older. Some other considerations are ethnicity can play a factor. So in women who are younger than 45, more breast cancer occur in African-American women. And women of African-American descent can more frequently get a type of breast cancer called a triple negative breast cancer that is more aggressive. So would play into a woman's decision on how and when to screen with that type of background. Breast density has a role too. Women's breasts are composed of a mix of fatty tissue and the denser glandular elements that produce milk. And the more that dense glandular tissue you have, for instance, a woman who's very dense can be up to 2 times more likely to get breast cancer than a woman with similar risk factors that has a fatty breast. So that alone is a risk factor. It's very important to maintain a healthy lifestyle. Obesity and elevated BMI have been associated with increased all kinds of cancers, including breast. And then there are factors that go into how long a woman has been exposed to estrogen throughout her lifestyle, or throughout her life. So a woman who started puberty earlier and had menopause later, or has had long-term use of hormone replacement therapy or birth control, may be at more elevated risk. And then there are the inherited genes, which I think we'll talk about a little bit more later, but things like BRCA1 and BRCA2, as well as other inherited genes, can contribute to it. One other thing is women who've had multiple breast biopsies in the past, even if they're benign and didn't show cancer cells, can have an elevated risk, as well as women who've had slightly abnormal biopsies that show things like LCIS or atypia are at increased risk. And then finally, women who've had a lymphoma or other conditions that require radiation to the chest are at elevated risk. So this very multifactorial. Having 1 or 2 or 3 of these doesn't mean you're going to get breast cancer, but can inform when and how you do your screening.
The take-home message that I get from your points, which I think are excellent, is that no 2 patients are alike. And it's important to focus on family history. It's important to focus on other medical conditions, on race and ethnicity. And I think it's such an important part of care today that we're really taking and handling patients as individuals. But I'm going to turn it back again to Dr. Zimmern. And what I'd like to do is really focus on a topic that is, quite alarming, which is the rise in colorectal cancers in young adults, early adult onset colorectal cancer. What's interesting is that screening has been so effective for colorectal cancer that we're seeing a decrease in the incidence, and yet we're seeing an increase in the incidence of colorectal cancer amongst younger individuals, people that we don't normally think need to undergo screening. You don't think of colorectal cancer in a 28-year-old as a cause of their symptoms or their bleeding. So, just tell us a little bit about these younger individuals and your thoughts on them and how we should handle them, because it has been reported in the New York Times and other media that this is a real phenomenon we're seeing, and no one is absolutely sure why this is occurring.
Yeah. I just want to start out by saying that for the audience, the reason I'm here is that colorectal cancer is the third leading cause of cancer death amongst men and women, but in women after lung and breast. So this is a very important topic and an important cancer to be screening for. And like you said, we've seen a decrease in the incidence of colorectal cancer amongst people over 50 because there have been many campaigns about proper screening, and people have been getting screening colonoscopies. And so we are catching them much sooner and preventing these cancers. But amongst young people, which we consider under 50 years old, there has been a rise in colorectal cancers over the past several years. Like you said, it's been in the New York Times, the Wall Street Journal. A recent example is Chadwick Boseman, who was Black Panther, and he kind of brought light to this topic because he was in his 30s, and no one really knows why this is happening. That's the real answer. There's no evidence or proof of any one thing that's been causing it. There are thoughts that there's something in what we call our microbiome, or in the bacteria and the viruses that are in our lives that change our biology. But there is definitely something in our environment that has changed. Everybody's DNA didn't all of a sudden change. So it's something in our environment that's being investigated heavily by researchers. There is definitely a component of people with genetic disorders. There is a component of people with family history. That's a huge part of this that I think a lot of people don't realize. It's not just people with a family history of cancer. It's also people with a family history of certain polyps, not all polyps. So you shouldn't be scared if your mom had a benign polyp, but there are certain polyps that do put patients at increased risk. So they themselves are considered high risk and should be screened earlier. So we're thinking possibly a fraction of these young onset patients could have been caught sooner had they known that their family members had what we call an advanced polyp. So some people, there's no explanation yet. Some people fall under these genetic syndromes. Some people have inflammatory bowel disease, which is Crohn's disease or ulcerative colitis. That puts them at increased risk. And then there's a cohort of people who we just can't explain. So definitely talk to your doctor about your family history, because that could shed some light and have you screened earlier. And there's a lot of research going on to try to figure out what's causing this, so we can really figure out who should be screened and when. Lowering the age to 45 is a start, but I have a feeling that's going to keep changing as more research is done.
Yeah, no, thank you, Dr. Zimmern. This is a really important topic. It's something that at the Northwell Health Cancer Institute, we are actively working with our colleagues at Cold Spring Harbor Laboratory, with researchers that are evaluating the factors that you've made. The microbiome, is this diet related? Is it overuse of antibiotics changing the normal bacterial content of the intestine? So to be determined, but clearly an area that we have to focus on. As we mentioned earlier, screening can detect cancers before symptoms appear, but you also really, we rely on patients. Patients know their bodies, and they know when something's changing. We have to listen to patients. We can't dismiss symptoms they're feeling, or if they feel off or a little bit different. Ben, one of the difficulties that we have, and I'm going to put myself in your group because we're of the same team in gynecologic cancer, is that many of the ovarian cancer patients, as you said, it was termed the silent disease, whispering disease. They didn't have a lot of symptoms, but they actually did have symptoms. It's just that we didn't associate them with ovarian cancer. So what are some of the early warning signs and symptoms that shouldn't be ignored? And I'm going to focus this on ovarian cancer because we don't really have a screening test per se yet for ovarian cancer.
Yeah, it's a great question. Unfortunately, the symptoms of early ovarian cancer can be very vague and can mimic some of the symptoms that people have every day that really don't mean that they have cancer, that there's a serious problem. For example, indigestion, bloating, pelvic pain, this sort of feeling that you're, before you even get halfway through your meal, you feel very full very quickly, or urinary symptoms, like you feel the need to go to the bathroom all the time, or that you're constantly feeling like your bladder is full. Irregular bleeding, whether it's before menopause, after menopause, after sex, or intercourse. The challenge is that we experience symptoms every single day practically. And the idea that if every time you had a symptom, you ran to the doctor, it certainly could really be quite harrowing. Generally speaking, though, cancer symptoms don't wax and wane. They tend to get worse and worse and worse over time. And I think if you're feeling a symptom, I think most ovarian cancer patients that I'm sure over the course of your career, Rich, that you've spoken to, in retrospect, when they look back, they say, now that I think about it, I was having this symptom that I thought was nothing, and it just wasn't, it was nagging me and wasn't going away. I think anything that persists for more than a week or so really is something that should be explored further. And I thought the beginning part of your question was really excellent, because I think the message should not just be to the patients, it should also be to the providers. And patients should be strong advocates for themselves. If they feel that their provider is not taking their concern seriously, or that they're writing off their symptom as a routine thing that probably is irrelevant, it's important for patients to be their own best advocates and to encourage their providers to really look further.
Well said, Dr. Schwartz. One of the most tragic things I recall in treating ovarian cancer patients was that quite a few patients over the years, that the way they presented was they said, no matter how hard I exercise, I can't lose weight. And the reason that they thought they weren't losing weight is because they had ascites, they had fluid in the abdomen. So I think this is so important. I think with cervical, probably the one thing that comes to light is abnormal bleeding, but that unfortunately usually means that it's more of an advanced disease or a cancer on the cervix than the early cases. So that's why screening is so important for them.
Yeah.
Thank you. Let's go on to, I think this is an area that I think is so important, because here's one of the areas where if we focus on it, we really can intervene. And it's the patients with a family history where the disease has a genetic component to it. At the end of the day, all cancers are genetic, right? Something has to go wrong that creates cells to divide abnormally and grow. So we should talk a little bit about genetic testing. We know that inherited conditions can significantly increase your risk of cancer. So I'm going to start with Dr. Zimmern this time. What should everyone know about their family cancer history, and who should we consider genetic testing on for those patients at an increased hereditary risk of developing colorectal cancers?
Sure. So, like I said before, and like you just said, family history is the key to all of this. There are certain genetic disorders that kind of everybody in your town will know that there's a family that has this disorder, and so everybody in that family needs to get screened for X, Y, and Z. But that's rare. More often than not, we find patients who just had one family member who had something. So it's really important to talk to your doctor. And even if it's not just colorectal cancer, there are other genetic disorders where if you have a family member that had breast cancer or endometrial cancer, uterine cancer, kidney cancer, those can be linked to genetic disorders that predispose you to colorectal cancer. When it comes to family history of colorectal cancer, the rule is if you have one first-degree relative, so that's a parent, a child, or a sibling who had colorectal cancer at any age, then you should get screened sooner. Whether or not you need genetic testing, that's a little bit trickier, and that's something you can discuss with your doctor. It can also be if you have several family members, second-degree family members that had colorectal cancer. And like I said, those other cancers, if those popped up in your family, it's something you should mention to your doctor. One other thing that could make someone get genetic testing is if they themselves had a colonoscopy that revealed many polyps. There is a genetic disorder that predisposes patients to have thousands of polyps. Sometimes there can be an attenuated version or kind of a muted version of that, where it's just tens of polyps or hundreds of polyps. But either way, that finding should prompt genetic testing, because that puts you at increased risk for colorectal cancer. In fact, your risk is 100% if you have that disorder. Finding 1 or 2 polyps, even 3 or 4 polyps, should not scare people. That's not necessarily this disorder, but if you're somebody that has many, many polyps, that's again something that's very rare, but that would prompt genetic testing as well.
And let's say someone has a recognized genetic syndrome, let's say Lynch syndrome or HN, hereditary non-polyposis colorectal cancer. How does that change screening? Normally we talk about screening every 5 years.
Yeah.
I assume
those patients would definitely get screened sooner. Depending on the genetic syndrome, you'd get screened at different ages. Some get started in their 20s, some would just get screened a little earlier in their 30s. The key is to talk about it with your doctor to see what is appropriate for you. A lot of these patients, though, would be recommended to have surgery, which would kind of preclude their further need to have any screening moving forward. So it depends on the syndrome and it depends on the patient, but definitely talk to your doctor and they can explain that to you, what's most appropriate for you.
Great. And Dr. Park, I didn't go in the same order intentionally, because you and Dr. Schwartz are going to talk next really about a syndrome, one of the first identified genetic cancer syndromes, an extremely important one that puts patients at a higher risk of both breast and ovarian cancer, and that's specifically patients who inherit the BRCA1 or BRCA2 gene. So tell us a little bit about breast cancer risk with those genes, and how do you screen in those patients? Is there modified screening?
Sure. So just a little bit more about BRCA1 and BRCA2 genes, or the breast cancer genes, and what they are. So they're genes that make proteins in the body that repair DNA, also called tumor suppressor genes. And everyone has them. Men and women have copies of these genes. And the mutations, the harmful mutations of them, are what causes cancers to grow, because it doesn't allow the proteins to do what they do best. So now we're not repairing DNA and we're letting cancer cells grow. And this can significantly increase a woman's risk of developing breast cancer if she inherits one of these mutations. So for instance, someone with a BRCA mutation has 45 to 85% chance of developing breast cancer by age 70, if with a mutation, versus 12% in an average risk woman. And Dr. Schwartz will talk about this, I'm sure, later, but also BRCA gene mutations increase the risk of ovarian cancer significantly. I think up to 40% in a woman with the mutation versus maybe 1.2% in the general population. And there's also a slightly increased risk of pancreatic cancer, I believe, in patients who carry these mutations. And then this also occurs for men. So men who inherit these mutations are at elevated risk for breast cancer, although less than women still. And then they have increased risk of pancreatic cancer and prostate cancer. So to your question about how this changes screening regimen for someone with a BRCA mutation, they may benefit from much earlier screening than 40. 40 is what we say for the average risk women. Someone who wants to screen and not have any preventative surgery could start as early as 25 to have annual screening. And then women with high risk also benefit from another test called a breast MRI, which is not a good test for general population screening, but for women like this, it can be a very valuable test that can pick up cancers when they're very early.
And in some of these patients where the risk is very high, even there's a consideration, I know, to sometimes do preventative surgery, which could involve removing the breasts and doing some form of reconstruction.
Yes.
Difficult decision, but it's one that has to be considered. Yeah.
Yes.
So, well, thank you. And I'm going to turn it over now to Dr. Schwartz, because this is clearly a major issue in GYN patients, who have inherited genes in BRCA1 and 2. And we should state that the frequency of these genetic mutations are about 1 in 400 in the general population, but in Ashkenazi Jewish women of Ashkenazi Jewish descent can be as high as 1 in 40. So it's not an uncommon finding, and a disease that we've said before we have difficulty screening for. So tell us about what preventative measures can be considered for these women, because we know most ovarian cancers present with advanced stage disease.
Yeah, thank you for that. I think the issues when it comes to these genetic abnormalities is that really depends on what individual patient is in their life and how young they are, how old they are, whether they have a family yet or not. We do know that birth control pills can help to prevent ovarian cancer. And so for those younger patients that haven't had a family yet, being on a birth control pill seems to reduce the risk. There's been a lot of conversations of late. And in fact, at Northwell Health, as you know, Dr. Barakat, we have a clinical trial looking at this. Exactly for those women who opt to have surgery, what is the benefit of having the ovaries removed or having the tubes removed or having a hysterectomy? There's a lot of discussions around this because it turns out that probably a lot of the BRCA-related ovarian cancer are actually fallopian tube diseases that spread to the ovaries. So we're actually exploring now in a clinical trial looking at preserving the ovaries for women that have BRCA mutations, because when you go through these surgical procedures, it puts you into what's called a surgical menopause, and that can have major implications for the quality of a woman's life. Beyond that, if you look broadly at what women can do to help mitigate their risk of getting a cancer, we mentioned earlier, I think it should be stated again, that every patient's individual situation is different, but obesity certainly contributes to the risk of to women developing cancers, and healthy lifestyle, healthy eating, exercise certainly can help. Most patients don't know that smoking, they know that smoking is bad for them, but I think most women would be shocked to know that even the smallest amount of cigarette smoking does significantly increase your risk of getting cancer. And again, I go back to, if you can get an HPV vaccine, it's a great thing to do. But I think generally speaking, those are the sort of technologies that we're looking at now. And I think it's an individual decision. Not every patient makes the same choices. Yeah. Certainly for those women who opt not to have preventative surgery, there's a real benefit to being seen more frequently by a gynecologist to be checked on a regular basis.
Yeah, no, that's great, Dr. Schwartz. I think there have been topics today that might seem like they're difficult and we need answers sooner rather than later. So I wanted to thank everyone for joining us today and really to thank our 3 outstanding panelists. One of the pleasures of being at Northwell Health and having the privilege of running the Northwell Health Cancer Institute is getting to know all of our clinicians that are here to help women specifically in this case, but to help all patients with cancer. And Dr. Park, Dr. Zimmern, Dr. Schwartz, really a pleasure to work with all of you. And, also want to remind for patients who are listening to this and for the lay public, to really partner with your healthcare providers. If you should have any further questions, always let your doctors know what's going on. Let them know your family history. Be your own advocate. We are here to help you and we will work with you. So thank you everyone for your attention today. And again, thank you to our incredible group of panelists. I thought this was fantastic.
I'm Belle Ruth Napperstack, and this is guided imagery that I've designed for people who want to assist their body's natural tendency to repair and heal. It's not a substitute for medical treatment, but a complement to it. More and more people find that using their minds in this way helps them relax, feel stronger, and get well faster. And it seems that when you take a more active role in your health, you generally feel better and do better. In fact, recent research has shown that using imagery can produce some remarkable changes in the body. It can alleviate pain, reduce high blood pressure, and boost the immune system, to name just a few. The program weaves several mind-body healing principles into the story it tells. It begins by helping you to relax and clear the mind. Then it calls upon your senses and memory to engage your imagination. And finally, it encourages you to experience a story that contains many healing images. All you need to do is settle in, relax, and let yourself listen. Some of the images will be more meaningful to you than others. Let your mind change or edit them as it sees fit. And because imagery is more effective when it is felt in the body, there are many feeling images for you here. You may find that as you use this over time, it has a stronger and stronger effect. Sometimes the images just naturally shift and change of their own accord. Don't get concerned about whether or not you're listening attentively enough. Relaxed concentration is best, but over time the words and images that are good for you will seep in anyway. If you notice your mind wandering, you can gently guide it back. Every now and then, this will bring forth unexpected emotion. If this is the case with you, see if you can allow the feelings to just come up and move through you, seeing it as a necessary kind of rinsing that's taking place. It won't hurt you to do this, and it may in fact be very good for you. Affirmations. These are positive statements that can be very useful in the healing process, a sort of reprogramming of your unconscious mind to combat negative thinking. For some people, affirmations are more effective than guided imagery. With any of this, take what is useful and leave the rest. If there is an image or phrase that is especially meaningful to you, try to play it over in your mind several times a day. When you brush your teeth, stop for a red light, or even better, just as you enter that twilight zone just before falling asleep. An especially powerful time to do this. So see if you can take this next while to commit yourself to this process of engaging the power of your imagination to help yourself heal by gently immersing yourself in this safe and easy process.
Hello, I'm Catherine Alfano, Vice President for Cancer Care Management and Research at Northwell Health's Cancer Institute and a proud member of the CATS Institute for Women's Health. I am so excited to talk to you today about how to improve the long-term health and well-being of our cancer survivors and the work that we are doing at Northwell to make that happen. But first, I want to introduce you to a patient named Rose. Rose is from a small rural community in the Midwest of this country. She had her own family farm where she grew really enormous sunflowers and even more enormous pumpkins that won the state fair multiple years in a row. When Rose was diagnosed with breast cancer, she was in her early 50s. And her surgeon came to her and said, Rose, we really need to take that breast. We need to do a mastectomy. Now, Rose was a very pragmatic person. And so she said, well, doctor, how long am I going to be in the hospital? What's the recovery going to be like from that? And her surgeon explained she would be at that time in the hospital for several days. And then she would go home and recovery would take several weeks, during which she would probably not have very good use of her left arm. Now, Rose was running her family farm by herself. Her children were grown and out of the house, and her husband was, in her words, a city slicker, and she shipped him off to his job in town every day. So she was having to do all of the farm work herself. So she thought of the animals that needed feeding and the cows that needed milking and said, I can't be out that far. I can't be out that long. So she opted for a lumpectomy instead of that mastectomy because she couldn't afford the downtime. And she also left the hospital with no pain medication because, again, cows needed to be milked that afternoon. She couldn't afford the downtime. So that worked for her for about 15 years until her cancer recurred. Now, at that point, she was in her 60s and she was no longer running her farm. She was renting out her farm space to a younger farmer. So when the surgeon came again and said, Rose, we need to take that breast. We need to do that mastectomy this time. She said, okay. And she also agreed to chemotherapy and radiation therapy for her breast cancer. Unfortunately, due to the way that the treatments that she had, she developed lymphedema, which is a complication that can happen all too often when we take some of the lymph nodes that are in the armpit area. Lymphedema causes an excess of lymph fluid to accumulate in the affected arm. And in Rose's case, she had a huge amount of lymph fluid and she really lost the use of that arm. Now, we have therapies that can help minimize the effects of lymphedema, but due to the fact that Rose was living in a rural part of America, she had no access to cancer rehabilitation techniques that would allow her to use that arm again. So patients really want to balance tumor response with function and quality of life. And I think that's what Rose's story really illustrates, right? She had to make choices, not just based on whether that was the best treatment for her cancer, but based on her need to function in her life roles and have a high quality of life after cancer. And I think that's what we are really after in trying to think about how to redesign oncology care so that we can achieve that balance between tumor efficacy on tumors and function and quality of life. Now, Rose's story is very common. So we have we have 17 million cancer survivors living in the United States today. And that is on its way up to 26 million cancer survivors by the year 2040. And that's because we're getting better at treating cancer. So people are living longer and longer after cancer. And it's also because our baby boomer generation is getting older and more of them are getting cancer. So the vast majority of people being treated for cancer and living for years beyond their cancer are also older adults over the age of 65 who come into their cancer experience with multiple comorbid conditions, multiple other issues besides their cancer that they're dealing with. And that has implications for the need to help design healthcare for them that's not just about attending to the needs of their cancer, but also about attending to all of their healthcare needs as a whole person. So I said there's 16 million cancer survivors today. Among women, the vast majority of them are breast cancer survivors, followed by uterine cancer, colorectal, thyroid, and melanoma. And here in the New York region, our numbers are very similar to that. So what we need to do, the fix, if you will, is we need to start thinking about survivorship or thinking about somebody's long-term function and quality of life and long-term health and well-being. We need to start considering that at diagnosis equitably improving multiple long-term outcomes at once. And this is true regardless of whether someone's going to live for weeks or months after their cancer or for decades after their cancer. So what we're trying to do, improving those multiple long-term outcomes at once, are attending to the fact that cancer causes toxicities to every major organ system in the body, depending on how you were treated, the different agents that you got, the different radiation you got, where you got that radiation, how much you got. Right, we have these toxicities that happen to every major organ system. We also have problems like fatigue, the psychosocial impact of being treated for cancer, things like depression, anxiety, the fear that cancer is going to come back, or the fear that there's going to be this late effect of cancer therapy. Problems like lymphedema, like in Rose's story, where you get that excess accumulation of lymph fluid. Problems with neuropathy, these are balance and gait problems where you either get numbness and tingling in your fingers or maybe in your feet, and then you're falling when you get up in the middle of the night to go to the bathroom. There's also financial toxicity, right, where a quarter of our cancer survivors are experiencing really material financial hardship just trying to pay their cancer bills. And all of this can really spiral into reducing that patient's ability to function in life, reducing their ability to participate fully in life, right? Whether that's caring, whether that's working, caring for their children, caring for their aging patients, fulfilling their community roles, and really also reduce their quality of life. So along with these outcomes, we're also trying to address the fact that we have disparities in our cancer outcomes by every socio-demographic that we know. So insurance status, race, ethnicity, immigration status. And we need to equalize the playing field and make sure that we are equitably improving access to quality care. And on top of that, we're dealing with the fact that we don't have enough clinicians to treat all of our cancer survivors. We don't have enough oncologists. We don't have enough primary care providers or nurses or any of our subspecialists like physical therapists who are needed to treat our cancer survivors. And on top of that, none of our clinicians get enough information in school on the long-term and late effects of cancer therapies. And one of the reasons for this is that the long-term and late effects of cancer therapies are constantly evolving because we're coming out with new ways of treating cancer every day. And so we're constantly having to research what the long-term and late effects of those new therapies are. So it's hard to keep up. So the current state of cancer treatment, because of all of those issues that I just outlined, is like a cancer patient and their clinician are standing on one landmass, and the rest of that patient's life is on another landmass. And there's this huge chasm in the middle. And the clinician is not standing there holding the right tools to help that patient get across that chasm. And those tools are access to the best treatment for that person's cancer, including access to clinical trials. Secondly, we're not doing a very good job of preventing toxicities of cancer therapies or treating toxicities to the extent that we can. And we're not doing a good job of following up patients for the rest of their life in follow-up care pathways that make sense for them. And this is not a Northwell specific problem. It's not a New York specific problem. It's not even a US specific problem. My colleagues and I from all over the world right now are writing a manuscript about how this is really a global problem in our inability to provide the kind of care for patients that really can follow them over the long term and optimize their long-term well-being and their long-term health. So what we're building at Northwell is really a bridge between that treatment and that person's the rest of their life. And that bridge is going to connect that patient with the best anti-cancer therapy for them, including access to cutting-edge clinical trials. Secondly, that bridge will help either prevent the toxicities by understanding whether a patient's at risk for certain things, or if we can't prevent those toxicities, we will embed patients in a surveillance system so that we are watching out for those things that we know they're at risk for, so that we can catch them when they're small, before they go on to develop 5 other problems that then you can't drive, you can't care for your aging parents, whatever it is. And third, we're building follow-up care pathways that are really tailored to what that patient needs, how often they need to come in, whether that's via telemedicine or in person, what kind of providers they need to see. It's tailored to what that person really needs for the rest of their life. And we're building this bridge with what we call health system science, meaning we're using a person's data and analytics in a way that actually helps us personalize the care that we provide. So building best-in-class survivorship care is really about integrating research and practice, winding those two things around each other like a double helix, because a double helix is so strong. So at the same time that we're delivering cancer care, meaning we're delivering that anti-tumor, that anti-cancer care, we're monitoring patients for tracking their symptoms, tracking their quality of life, their ability to function in life, and facilitating referrals for those problems. We're also giving them their medical surveillance, the imaging, the labs that they need to detect recurrences, to detect subsequent cancers, to make sure we're monitoring for the late effects of cancer therapy, like those cardiac toxicities that can come 10 years later. At the same time we're doing that, we're making sure that we're creating what's called a true learning healthcare system, where analytics are really driving personalized care. So we're able to predict what a given patient needs, what they're at risk for, and their response to a given intervention. And we're also collecting consent so that we can use a patient's data and their saved blood, their discarded tissue samples, so that we're creating a true registry of patients going forward to understand that evolving paradigm of the long-term and late effects of cancer and what works for whom as our cancer treatments change. So let me tell you just a little bit about how we're building these three things at Northwell. So in terms of access to clinical trials, we're building a center for genomic medicine where we're really going to be able to better understand a given patient's tumor, what's feeding that tumor, and how do we turn off that food so that that tumor can't grow anymore. And we'll be able to seamlessly connect a patient to the best anti-cancer therapy for that specific tumor that they have. Secondly, on treating toxicity, we want to embed patients in what's called that prospective surveillance model, meaning that we're going to anticipate what their risk is of issues going forward, deploy preventive interventions if we can, or if we can't, we will be able to pick them up because we're monitoring patients for the development of those things. We'll be able to pick up that neuropathy, pick up that lymphedema that I told you Rose had when it's small, and facilitate a referral to our multidisciplinary care clinicians or programs in the most efficient way possible. And that includes giving patients self-management materials. So it's not just that we have this whole team approach to helping our cancer survivors, right? My whole career, we've been arguing about, well, who should provide ongoing care for our cancer survivors? Is it an oncologist? Is it a primary care doctor? Is it a nurse practitioner or a PA? And the answer is yes, yes, and yes, and a whole lot more. So what cancer rehabilitation, like the people who help treat the lymphedema I talked about that Rose had, palliative care clinicians for complex symptom management, psychosocial care clinicians for that depression, anxiety, that fear of cancer recurrence, exercise and nutrition programs and integrative medicine programs that are available at the Katz Institute, as well as lots of other kinds of clinicians like cardio-oncologists, onconephrologists, genetic counselors, dentists for people who have had head and neck cancer, and many, many other kinds of clinicians. And again, one size doesn't fit all here. Not everybody needs all of these clinicians, but we need a system that's monitoring patients to get them to the right programs and clinicians that they need, and also helps them self-manage as much of the issues, as much of their health as they can, right? Empowering that patient, engaging them in their care, telling them what they can look out for in themselves. You know, what's a headache and what's a brain tumor, right? And helping to also educate that caregiver in the home, whether it's that spouse or partner or that adult child or that friend or other family member who's helping to provide care for our cancer survivor. They need our support and our self-management help as well, so that we can really truly build this team approach to care. Third, we're building these follow-up care pathways so that we're really going to help monitor patients for what they need as they transition out of oncology care for those who transition out, or as an aside to the oncology care, so where we're able to manage the ongoing effects of cancer. And again, personalized to what a patient needs. It's really important that we're going to build this to seamlessly integrate oncology follow-up care and all of our subspecialists, because we don't want the patient to have to coordinate all that. The system needs to coordinate all of the pieces of this care for that patient. Otherwise, it's just too complex. And we also know that we want care to be delivered as much as possible outside of clinic walls. If you're having trouble sleeping, you need help with that, and you need information on how you can sleep better at 3 a.m. when you're lying there awake, not the following Tuesday when you can get in to see a clinician, right? So we need to get that information to our cancer survivors in a timely way at what we call point of need outside clinic walls as much as possible. So I want to come back to Rose. Right, so Rose lived for another 10 years after her breast cancer recurrence, when she ultimately developed heart failure, and that is what took her life. Now, there were probably, the heart failure could have been a late effect of cancer therapy because she was given a chemotherapy that was known to be cardiotoxic, meaning it affected the heart. Or it might have been a late effect of her breast cancer radiation because we irradiated her left chest wall, including the heart. There were probably opportunities for prevention of that heart failure that we missed in Rose's case. But this was not too sad of a story, because at the time that Rose died, she had lived to raise her 9 children. She had 15 grandchildren, and she had many, many more great-grandchildren that she had lived to see being brought into this world. I don't think I understood just how profoundly affected I was by Rose's story until many years later, when I realized that I've dedicated my life to making sure that patients like Rose get the comprehensive care that they need to achieve their full and best lives after cancer. Because you see, Rose was my grandmother, and she taught me that this bridge that we need to build to connect patients with this comprehensive care is a big, hairy, audacious goal, but it's one worth doing. Because as my grandmother always said, it's better to shoot for the stars and hit the moon than shoot for the fence and hit the dirt, right? We have so many patients to be helping. We cannot afford to be lying face down in the dirt. So at Northwell, we're going to be shooting for the stars. And I hope that you'll join us in this. Thank you very much for your attention today.